The incidence of non-Hodgkin lymphoma in adolescents and young adults has increased over the last 25 years, so it is probably good while we're here in Chicago at the ASH meeting on hematologic malignancies to discuss clinical trial availability in adolescent and young adult patients with non-Hodgkin lymphoma. And to do so, I'm talking to Dr. Melissa Crawley, MD, who is a fellow, correct, at the University of Tennessee Health Science Center. Now, let's start at the beginning. Why did you do this study?
So, adolescent and young adults, non-Hodgkin's lymphoma patients, it's a vulnerable population. They have higher risk, as you said, of relapse compared to normal or to pediatric and adult counterparts. And they also have lower rates of clinical trial enrollment compared to both of those subsets.
Well, a lot of times they're actually stopped from being in a clinical trial. That's one of the exclusion criteria.
It's difficult in some cases because they often find themselves in a place where they may not be allowed to enroll in adult clinical trials that they may be phenotypically qualified for. And they may be prohibited from enrolling because they are under age of 18.
So what did you actually do? How did you do this study?
So we performed a keyword search from clinicaltrials.gov of non-Hodgkin's lymphoma. That yielded over 700 results. We excluded any studies that were limited to transplant conditioning regimens or that did not contain novel agents. And we looked at those, at the remaining studies, there were 404, and we looked at those to see whether or not they contained novel agents, what the novel agents were, and whether or not they were enrolling patients between the ages of infancy to 18 or over 18 and over. We also looked to see if if institutions that those trials were being performed at had a COG member institution affiliation, so Children's Oncology Group.
So what did you find when you went through the data?
So we found that of the 404 trials that we included in our analysis, that only 15% of those trials enrolled patients under the age of 18. We found that of the remaining 85% that were excluded to patients over the age of 18, that the bulk of those trials did enroll patients who had the 5 most common subtypes of non-Hodgkin's lymphoma that you see in adolescent and young adult patients. We also noted that a little over half of those trials were being performed at institutions that did have COG affiliation.
Now, as you mentioned, adolescent and young adult patients with non-Hodgkin lymphoma have higher relapse rates and lower survival rates than their pediatric and older adult counterparts. But what can we do about it?
Well, I think that what we found here really highlights the need for increased collaboration between adult and pediatric oncologists and adult and pediatric centers, including patients who are appropriate for any clinical trial, if possible, to be enrolled. And there are a number of barriers that we need to examine to make that happen. For example, is one of the reasons why we're not including pediatric patients in trials for patients who are over 18 is that because of the greater administrative burden, difficulty with consenting younger patients, looking at all of those things that prevent us from considering patients who might benefit from clinical trials. There was one other abstract that was that's being presented at this conference that I wanted to highlight. It was abstract 26, which was a study of ALL and AML patients from underrepresented minority and AYA status. There was a merger between 2 COG institutions in Chicago, Rush and University of Chicago. They merged with Stroger-Cook County, and they made a combined IRB and a combined research group, and they saw how their COG trial enrollments increased because frequently we noticed that in young adult patients and patients up to the age of about 39 that they have some benefits in being included in pediatric-like regimens for leukemia. So that's a potential strategy, would be combining forces with adult and pediatric centers to look at and see how we can improve clinical trial enrollment.
Your study raised a number of questions. We know that these kids do a little worse in terms of relapse. Is it sometimes because they haven't been enrolled in clinical trials? Maybe we have not got the optimal therapy yet?
I think that that's a question worth considering. One thing that we noticed that was interesting is that blinatumomab, which is FDA approved for B-ALL, was not a part of any clinical trials for patients under the age of 18. This is an agent that's been shown to be very effective in adult ALL and has also been shown to have some efficacy in early clinical trials of non-Hodgkin's lymphoma. Understanding why pediatric patients or adolescent and young adult patients who might benefit from that, why we don't have trials opening to those patients is something worth studying.
So given the fact you did raise a few questions in this study, what are you going to do next? Are you going to do more along these lines, trying to figure this stuff out?
So we're looking into ways to determine how we can better enroll patients in adult trials that are appropriate for it. And it's in the year of the Cancer Moonshot, where we have increased funding and where we're really focusing on immunotherapy as a means of improving cancer care. It's something that we really do need to consider.
Well, Dr. Crawley, thank you very much for your time. We have a variety of reports coming out of this meeting, so please check ASH Clinical News for that, and here online for some of the video interviews. And I am Rick McGuire, Executive Editor for American Medical Communications.